All right. So thanks to Nanjan and the organizing team for inviting me. So the outline is regarding the background and the rationale, the evidence, critique, the guidelines and the reviews, and the future studies. So the brain metastasis, a select group of patients, a survival benefit is seen with surgical resection. The whole brain radiation has been a standard of care to improve the local control. However, there has been no survival benefit and there were concerns of cognitive impact. This was in the non-hippocampal sparing era. The retrospective information post-surgery followed by the post-op cavity SRS versus post-surgery followed by whole brain radiation. Some results have been similar with respect to the control and some have been worse. But in spite of the lack of robust evidence, cavity-directed stereotactic radiosurgery has been practiced and preferred by many a neurosurgeon. 2 randomized control trials were designed to answer the utility of this post-op SRS by generating level 1 evidence. So one was with regards to Mahajan et al., in which they sort of compared surgery followed by post-op cavity radiosurgery versus observation. And the other one was by Brown et al., in which they did a post-op cavity radiosurgery versus whole brain radiation. So this is the first trial from Mahajan et al. The study objectives were primary, the endpoint was local control, the secondary was rate of distant mets, overall survival, and the need for whole brain radiation. This had to be a 3 lesions, and in which at least 1 lesion had to be grossly and sort of totally resected. And then the patients were randomized with respect to the radiosurgery versus observation, and then a follow-up MRI schedule. So the inclusion criteria, again, a complete resection of at least 1 or even more. The resection cavity, they put up a constraint of diameter of 4 centimeter, and the unresected brain mets had a maximum dia of 3 centimeter. The KPS as per inclusion was 70, and an active extracranial disease was included. The exclusion criteria was that the patients who had received prior radiation and or radiographic evidence of leptomeningeal disease, and the primary tumor being small cell lung cancer, SCLC, lymphoma, leukemia, or multiple myeloma in pregnant females. The radiation technique was to the SRS to the target volume, the surgical cavity with a 1 millimeter circumferential margin. The doses, as the volume was sort of increasing, the dose was getting reduced. It was prescribed at the periphery. The remaining 2 metastases also underwent stereotactic radiosurgery on the same day, and the dose constraints were with respect to the brainstem and the chiasm. So this was, that is what they presented in Lancet, and this was the sort of inference that it could be an alternative to whole brain radiotherapy. These were some of the details. I'll just skip the slides, and they found that there was a local recurrence, sort of a betterment with respect to freedom from local recurrence with respect to the SRS. Also, with respect to the size of the brain metastasis, so when they did a multivariable analysis, they found out that SRS was better, and the size of the brain metastasis also mattered. So size less than 2.5 centimeter, they were showing a better control. The overall survival was not statistically significant. So other subtle findings were that the 12-month freedom from local recurrence was 43% in the observation and 72%, which was shown. The cause of death was neurological in the observation group was 64% and 48% in the SRS group. 30 of the 65 patients in the observation group subsequently had whole brain radiotherapy, and even 24 of 63 patients, that is 38% of the patients in radiosurgical arm also had whole brain radiotherapy. Also, this was an interesting finding that the leptomeningeal disease, even in the observation group, was 16% compared to 28% in the SRS group. The other trial was done by Brown et al., in which they randomized patients to either post-op cavity radiosurgery versus a whole brain radiation option. The primary endpoint was cognitive deterioration-free survival. That is, they were looking at cognitive outcomes, neurocog outcomes, and overall survival. More or less the same criteria. They had increased the number of brain mets to 4, the unresected lesion being 3 centimeter. Here in this trial, there was no concept of a total resection. There were patients who had also undergone a subtotal resection. The cavity was less than 5 centimeter, and it was a gamma knife or a Linac-based sort of criteria for the radiosurgery. Exclusion criteria remaining more or less same with respect to the prior trial. Radiation technique, the SRS arms, again, as the size of the lesion increased, the dose came down. It was prescribed to the highest isodose line to the to the periphery with a 50 to 90% of the Dmax dose. This is what they published, and this is what they used, that SRS radiosurgery should be used. So the prior trial was could be, and this was should be. Some of the patient parameters, which were well balanced along with the two arms. Now here, the cognitive findings were better with respect to the SRS, that is the neurocognitive. As we can see, it was significantly better. But with respect to the local control, the surgical bed control, distant brain, LM, the leptomeningeal disease control, all were showing a finding towards the whole brain. That is, it was favoring the whole brain radiotherapy arm. So surgical bed control, they wrote it as similar. However, it was better with the whole brain arm. And this is what the reason they put up, that that there was some subtotal resection in the study. The surgical bed control was treated by the treating physician, and the higher SRS dose, probably as we sort of, first thing was that as we were going ahead with a higher surgical cavity volume, the SRS doses were going down. And even with the higher dose, they were thinking more in terms of pseudo progression, which would have sort of an imaging false positive for a recurrence. And the patient populations here also sort of differed. And they said that the lung primary was 59% in this trial versus 20% in the Mahajan et al. Trial. Other subtle findings, there was no difference in the frequency of the local salvage therapy after SRS. That is, patients had to undergo either surgery or radiosurgery. In the SRS group, 20 of the 98 patients received, that is around about 20%, received whole brain radiotherapy as a component of salvage therapy. And grade 3 was more or less similar with respect to both the arms. There was a critique following these two trials, and couple of them being published. So the observations and inferences were that the leptomeningeal carcinomatosis after surgery, it was an iatrogenic failure. A single fraction dose was insufficient for a local control of lesions greater than 2.5 centimeter. The control of post-op SRS was similar to SRS alone. And the hippocampal sparing, so that was also an option that was not studied. And neurological deaths were sort of put up in this flowchart, like the local control being higher for a whole brain radiotherapy arm, and the toxicity also becomes higher. So then we come to how do we sort of pragmatically sort of implement this. So one was regarding the contouring guidelines for the post-op completed resected cavity. And this was to take into account with respect to failures. So if the patient was having a preoperative dural contact, we need to take the dural picture with a 1 to 5 millimeter along the bone flap, and along the venous sinus, again, we should take a margin of 1 to 5 millimeter. The dural also with respect to 5 to 10 millimeter if there was a bone flap. So some of the findings, this they have put up the venous sinus which is involved, and therefore we need to take into account the target volume post-operatively. Similarly, for a dural contact, to put it up till the dural sort of the bone flap interface. And this is the non-dural compared in the pre-op, but in the post-op, you need to take into account the, I would say, the surgical manipulation. So you need to take the volume here. Again, the volume and timing, very important. When do we start? So both the trials were taking up the patients within 3 to 4 weeks. Now this study sort of put up two volume sizes, that is 2 centimeter sizes. So this was more than 3 centimeter, and they showed that there was a drastic reduction in the cavity size. Whereas the lesion, if it is less than 3 centimeters, the cavity size or the cavity doesn't shrink to that much. So probably with a higher cavity size, and if we want to go for a single session, we need to sort of wait for 3 to 4 weeks for that matter. But for a tumor size cavity less than maybe 3 centimeter, we can start the things a little early. And there were some sort of sarcastic comments, I won't call it, but sort of food for thought, that they said that it was mostly water inside the cavity. And therefore they said you should also take care of the marginal region rather than the cavity itself. Again, some of the studies with respect to the dural contact, again, mentioning with regards to the control and the dose response, again, with the PTV size. So as the PTV size is increasing, you need to either increase the dose or fractionate it. So therefore, you need to give a higher dose, and especially with respect to the radio resistance. So once you are finding a brain metastasis from a radio resistant lesion, you need to increase or step up the dose, either increase the dose or do a fractionated sort of a regimen.
Pre-operative. So sorry to interrupt, but
yes, we
are short of running out of
time. All right, ma'am. So I'll just quickly, pre-op versus post-op. Again, a study was done. Pre-op radiosurgery versus post-op whole brain doesn't make much of a difference. The current status is to fractionate basically with the larger lesion so that we can give a higher BED with respect to volumes. And these are the practice guidelines that you can do. You should do a post-op SRS and also do a post-op SRS with respect to neurocognitive. Rest are all level 3 evidences. You need to counsel the patient with respect to the leptomeningeal disease. The future studies are with respect to either single fraction versus a fractionated, and also preoperative versus post-op. We're looking at either leptomeningeal disease or a composite endpoint event. That is, you're looking for more events and you're sort of adding them up statistically. All right. Thank you so much. Thank you.